Hello everyone, my name is Dr. Park. Today I'll present a mortality study for hypothermia treatments after out-of-hospital cardiac arrest based on NIS database from 2016 to 2018. Hypoxic ischemic brain injury is a devastating consequence of cardiac arrest. Animal and human data has shown that mild induced hypothermia has neuroprotective effects, but the mortality benefits of therapeutic hypothermia for patients resuscitated after cardiac arrest remains uncertain. Here we conducted a study to assess the mortality outcome in a therapeutic hypothermia intervention group compared to normal thermia group. We conducted a retrospective analysis of 3 years of the NIS database from 2016 to 2018. Patients were selected using ICD-10 diagnosis codes with a principal diagnosis of cardiac arrest and with ICD-10 procedural codes for therapeutic hypothermia. Each groups were stratified with age, race, sex, diabetes, hypertension, heart failure, history of PCI, CABG or MI, and clinical data including Charlson Comorbidity Index. Primary outcome was in-hospital mortality, and that was calculated by mortality level, mortality variance, logistic regression analysis. So in the result, the demographics were pretty similar during the 2016 to 2018, including age, race, sex, diabetes, hypertension, heart failure, history of PCI, CABG, or MI proportion. But there is significant difference between groups in terms of mortality, in hospital mortality actually. And then the odds ratio in 2016 was 1.25. 95% of confidential interval was 1.02 to 1.52. P-value was 0.033. In 2017, the odds was elevated to 1.32. Interval was 1.09 to 1.60 with p-value 0.005. In 2018, the odds were further elevated to 2.5 with 95% confidential interval of 1.96 to 3.19. P-value was smaller than 0.001. Patients admitted with a primary diagnosis of cardiac arrest, indicating an out-of-hospital cardiac arrest, who received therapeutic hypothermia after resuscitation had a higher incidence of in-hospital mortality. Furthermore, mortality odds ratio was significantly elevated and increased year after year. In the targeted temperature management trial 1, which was published in NEJM in 2013, a targeted temperature of 33 degree didn't have a mortality benefit compared to that of 36 degree. The trend of decreasing utilization of therapeutic hypothermia by 0.45% yearly may be related to that, but the p-value was greater than 0.05. With an open label trial with blinded assessment study, TTM2 trial, also known as, showed no significant improvement of functional outcome in hypothermia group compared to non-hypothermia group. There was no 6-month mortality difference. However, in contrast to that, our study showed hypothermia actually led to a higher incidence of in-hospital death. Further studies are needed to better understand the advantage and, more importantly, potential danger of hypothermia. Thank you.